Hello all, let us understand some disorders relating to the cardiovascular system. So the first is coronary artery disease. So in stable angina, what happens? There is a atherosclerotic narrowing, so decreased blood flow when demand is increased in exercise. ECG normal at rest and ST depression on exertion. Second is an unstable angina, in that there is a plaque instability or rupture, so decreased blood flow at rest also. ECG showing ST depression or T wave inversion. Third is in MI, there's a complete coronary artery blockage will be there, necrosis is there, so ECG show ST elevation, and the silent MI decreased blood flow without chest pain, so ST depression or T wave inversion will be there. Next disease is the hypertensive heart disease, in that there is a systemic hypertension, in that BP more than 140/90. Myocardial oxygen demand is increased, structural changes are there. ECG show left ventricular hypertrophy, ST or T changes. Echo will show ventricular hypertrophy along with left atrial enlargement. Second is an hypertensive cardiomyopathy. Due to chronic hypertension without other causes for cardiomyopathy, ECG will show T wave inversion and left ventricular hypertrophy. Echo will show left ventricular hypertrophy, left atrial enlargement. Valvular heart disease, in that first is an aortic stenosis, so there is a narrow aortic wall. ECG show left ventricular hypertrophy with high QRS. Second is an aortic regurgitation, incompetent aortic wall, so there is a backflow from aorta to left ventricle, so ECG left ventricular hypertrophy with high QRS. Third is in mitral stenosis, there is a mitral wall narrow with obstruction to the blood flow from left atria to left ventricle during diastole, so left atria enlargement with broad notch P wave. And in a mitral regurgitation, incompetent mitral wall with left atria enlargement. In cardiac arrhythmias, first is an atrial fibrillation, there is a no distinct P wave, irregular RR interval. Second is an atrial flutter, sawtooth flutter F wave, atrial rate more than 250 to 350 per minute. Supraventricular tachycardia, regular rhythm, narrow QRS complex. Ventricular tachycardia, wide QRS complex. Ventricular fibrillation, no identifiable P wave or QRS complex. In a bradycardia, regular rhythm, rate less than 60 per minute, normal P wave. Heart block more than dropped QRS and PQRS complexes independent. Okay, so next disease relating to the heart will be. Next is in pericardial diseases. First is an acute pericarditis, in that there is an inflammation of the pericardial layer of the heart. So in that what happened, diffused ST elevation or PR depression will be there. Second is in pericardial effusion, excess accumulation of fluid in the pericardial layer. ECG usually normal, may show voltage QRS complex or electrical abnormalities with a large effusion. Third is in cardiac tamponade, rapid accumulation of the fluid in the large volumes of the layer. Increase intracardial pressure, so in that sinus tachycardia or a low voltage QRS complex. And fourth is a constructive pericarditis, fibrosis, calcification, thickening of pericardial layer. ECG usually normal or may show low voltage. Next is an endocardial disease. So in that first is an infective endocarditis because of infection of endocardium, usually involving heart wall, because of a bacteria, streptococcus, staphylococcus. Symptoms like fever, chill, malaise, new changing murmurs will be there, and a treatment will be IV antibiotics and surgery. Second, whereas in non-bacterial thrombotic endocarditis, sterile deposition of a fibrin and platelet on a heart wall, usually associated with systemic diseases. Symptom like onset is silent and recurrent systemic emboli, and treatment underlying disease. Next is an aortic diseases, in that first is an aortic aneurysm because of abnormal or a permanent dilatation of segment of aorta more than 1.5 times the normal. Second is an aortic dissection, in that tear in the intimal layer causing blood to enter in the medial and create a false lumen. Third is an intramural hematoma, bleeding within the media of aortic valve without tear. Next is in rheumatic heart disease, in that first is a rheumatic mitral stenosis, in that fibrosis and a commissural fusion of mitral wall leaflets and narrow mitral orifice. ECG show P pulmonal right axis deviation and chest X-ray left atrial enlargement and pulmonary venous congestion. Secondly, in a rheumatic aortic wall disease, in that fibrosis, thickening and calcification of aortic wall leaflet. Stenosis and regurgitation will be there. ECG show left ventricular hypertrophy. Chest X-ray post-stenotic dilatation of ascending aorta with left ventricular enlargement and wall calcification and thickening. Reduced opening will be seen on an echo. Okay, so complications like heart failure, angina, syncope, stroke, infective endocarditis will be there. Okay, so this should be remembered. Thank you.